Good afternoon, everyone, and welcome to this month's Ambassador Circle webinar. Today, we are going to be taking a deeper dive into women and trachoma. I would like to first introduce myself. I'm Amanda Grover, Associate Director in the Ambassador Circle, and I'd also like to take this opportunity to introduce the rest of my Ambassador Circle team. So first, we have Anne Venable, our Senior Associate Director in the Ambassador Circle. Anne is going to be working our Q&A in the Q&A. So if you have any questions, please put them in there and Anne will see them and elevate them up so that we can make sure that they are answered. Next, we have Ursula Hamilton, Senior Associate Director in Major Gifts. Ursula is going to be working the chat for us. So she's going to be putting all the helpful links and answering any questions that you put in the chat today. And next, we have Alden Mahler-Levine, our team admin, who's going to be working the slides.
Hi, everybody.
Thanks, ladies. And without further ado, I would like to welcome and introduce our panel of experts today. First, we have Kelly Callahan, who is the director of our Trachoma Control Program. Kelly oversees our Trachoma Control Program in partnership with 5 countries, treating more than 37 million people annually. Kelly earned her Master's of Public Health from Emory. She was the Assistant Director of Program Support for Carter Center Health Programs recently, or before this, and she also served in the Peace Corps in Cote d'Ivoire and received a Distinguished Humanitarian Service Award from the Peace Corps. Kelly, thank you so much for joining us this afternoon.
Thanks so much, Amanda. It's really a pleasure to be here.
Also joining us, we have Dr. Angelia Sanders, Associate Director in the Trachoma Control Program. Angelia, congratulations on recently receiving your doctorate. And we also have Kim Jensen, Associate Director of the Trachoma Control Program. Ladies, thank you so much for joining us this afternoon for what is surely going to be an interesting and thought-provoking presentation.
Thanks again, Amanda. It's really a pleasure to be here.
Wonderful. Go ahead.
I was just going to say it's a pleasure to be surrounded by such strong, vibrant, passionate, and focused women.
Absolutely. We love to see it. So Kelly, do you want to get us started?
Yeah, I'd love to. And I'm going to go ahead and ask Alden, if you would. Alden, can you go ahead and put up the slides? So today, with my colleagues, both Dr. Sanders and Ms. Jensen, we're going to talk about women in trachoma. And this is especially important to me as I am fortunate enough to lead a team of these 2 women and a greater team towards the elimination of trachoma as a public health problem. I want to take a moment to talk about trachoma and what is trachoma. Trachoma is the leading cause of infectious blindness worldwide. It is transmitted person to person. It is transmitted through fingers, flies, and fomites. So if we look at the circle that starts in the far corner with a small child and some flies buzzing about his head, and exposed human waste, what happens in the beginning of the life cycle is exposed human waste attracts flies. And then these eye-seeking flies called muscosorbin move from child to child. Children are the reservoir of this infection. Children between the ages of 1 and 9 harbor this disease, chlamydia trachomatis, which is a bacterial infection. And when one child has chlamydia trachomatis, it is easily then transmitted from child to child. What happens is when a child has a great element or increased chlamydia trachomatis, they begin to start experiencing nose and eye discharge. That discharge contains this bacterial infection. These eye-seeking flies will land on a child's eyes and nose to take up the chlamydia bacteria on their feet and legs, and then use that as nourishment and to feed their larvae. As that process continues, that eye goes from child to child, taking that chlamydia trachomatis from person to person. Unfortunately, there is also the prospect of a child or even a mother or another person, a father, a brother, a sister, wiping their eyes or their nose and then shaking someone's hand, and then that person touching their eyes or nose and also spreading chlamydia through the fingers. And lastly, through towels, you'll see a mother wiping the face of a child. Dirty towels, or often the hem of a skirt is used to wipe a child's face to clear the child's eyes and nose of their discharge, and then using that towel repeatedly over time. And then what happens repeatedly as the chlamydia trachomatis builds up inside the system, the human system, eventually the inside of the eyelid starts to build up this reservoir of infection. The infection starts to infect the eyelid. And as the eyelid starts to become more and more infected, the follicles in the eyelid start to get bigger and bigger and bigger and bigger. And if you look down at the bottom of the screen where it says scars inside the upper eyelid, eventually those follicles that have begun to scar start conjoining. And as they conjoin, they scar the inside of the eyelid. And as that scar gets bigger and bigger, it gets tighter, and therefore causes the eyelid to then contract upon itself and pull itself in. The eyelid then turns inwards, and every time a person blinks, their eyelashes scrape their cornea, causing their cornea to eventually be cut by their own eyelashes and eventually causing blindness over time. A person grows into this disease. They have the reservoir of infection between the ages of 1 and 9, but then they start growing into the scarring eventually between the ages of 20 and 45. Usually we'll see the most intensive scarring. We combat this disease through what we call the SAFE strategy: surgery, antibiotics, facial cleanliness, and environmental improvement. This fly, Muscus sorben, breeds on human feces. So we try and teach people how to build latrines and to assist them in building latrines. Once human feces is inside of a latrine, the fly cannot use that feces anymore. We also teach facial cleanliness as part of our health education program. If we have the eye and nasal discharge removed from the face, then it cannot transmit from person to person. Antibiotics treat the infection. Pfizer gives us the largest single drug donation in the world. We have received over 207 million doses of antibiotics from Pfizer. This keeps the infection low, it keeps it controlled. And then lastly, surgery. That is the final stage when when the eye has actually started to change, where a person's eyelashes have increased to the point where we have to cut the eyelid and rotate the eyelid back up. Very simple surgical procedure, takes about 20 minutes, but it is mentally challenging and it is scary no matter what. The Carter Center has been able to perform over 854,000 sight-saving surgeries in the countries in which we serve. Currently, we work in Ethiopia, Amhara, which is ground zero for the trachoma problem in the world. Amhara harbors the most known trachoma at this point in time. We also assist Mali, Niger, South Sudan, and Sudan. We believe South Sudan rivals Amhara in terms of its prevalence of trachoma, but we don't know yet because we have not been able to finish baseline mapping in South Sudan. In the past, we have assisted Ghana to reach their elimination thresholds, Nigeria, and Uganda, all successful programming. The magnitude of the problem is such that the Carter Center started this work in 1999. As many of you know, President Carter was a pioneer in so many things in his life and in the neglected tropical diseases. President Carter believes health is a human right and that people do not deserve to suffer from these diseases that have been neglected for far too long. Trachoma is one of those neglected tropical diseases. So President Carter decided with the Conrad N. Hilton Foundation in 1999 that we needed to do something about the world's leading cause of infectious blindness. We began with a health education program, and in 2001, we pivoted to start looking at mass drug administration. President Carter went to Pfizer and asked for a drug donation, and in that, Pfizer started the drug donation program. Since that time, we've been able to distribute over 213 million doses of Zithromax as the Carter Center. That number is far higher in terms of the global program. We've also been able to assist over 859,000 people in sight-saving surgeries, over 60% of them in women since we started tracking those that were women in 2012. We also have worked in almost 99,000 villages with health education and trained almost 390,000 people and helped build over 3.6 million latrines. Just the magnitude of the problem, this doesn't really show the global magnitude. It shows the purview of where the Carter Center works. We're trying to assist 37 million people. Currently, 136 million people are at risk of going blind to the effects of trachoma. Carter Center works with 37 million of them, currently in 5 countries. Mali is close to the elimination finish line, and we believe in the coming months to the coming year, we will be able to submit a dossier to the World Health Organization validating that Mali has finished their work. However, in Niger, we have remaining surgical services. Only 33% of that population have access to a latrine. So we have a heavy program of latrine building and mason training so that they can continue building latrines in their community. In South Sudan, as I said earlier, baseline mapping is not finished yet. We do not know how widespread trachoma is there. But from my work in that country in 2000 and 2001, it's the worst trachoma I've ever seen in my life. I saw a 5-year-old boy once, 5 years old, that had bilateral TT. He was suffering from the late stage effects of this disease at the age of 5 and required surgical services. We have to conduct, where we know in South Sudan, over 50,000 TT surgeries. There's very few TT surgeons. 3 million doses of mass drug annually are required, and we have 10 to 15 more years of mass drug administration in the areas where we understand that trachoma is a problem.
I have a quick question for you about South Sudan, if that's
Sure.
all right.
Of course.
So with the baseline mapping, is there a target date to be finished with that, or is there are just too many limitations right now to be able to project that out?
That's a great question. There was a target to map about another third of the country. The UK government was funding that. And unfortunately, many of you have heard recently about the UK government cutting their neglected tropical disease funding and their development aid funding. So only about 1/6 of the planned area that needs to be mapped will be mapped this year. And the Carter Center would like to continue pushing for partners and donors to provide support to map this. We would love to see the map finished by the end of 2022. But of course, the UK government reducing their funding will set us back in the first portion of mapping. And then phase 2 of the mapping, we currently don't have a donor or funding to conduct that. So right now, we're very hopeful, and we're continuing our programming in one specific area because we've already mapped that. The Carter Center mapped that area a long time ago. It's an excellent question. Thank you.
Thank you.
In Sudan, we require about 35,000 more surgeries to be conducted and 2 million annual doses of mass drug administration. This will take about 5 to 8 more years of mass drug administration to get the level of disease down where we can believe that it's controlled. And then we have a mass influx of refugees in Sudan, and they require our assistance. In the Amhara program of Ethiopia, as I said, this is ground zero that we know right now. There are an estimated 150,000 more people that require TT surgeries. we only have 264 TT surgeons, only 30 of which are women. We require 17 million doses of mass drug administration annually in the area in which we serve, the Amhara region, and this will require 8 to 10 more years of mass drug administration. So the scope of the problem, the magnitude of our problem is still very, very high. And we still have a long way to go in terms of these 37 million people under the Carter Center's purview to stop them from going blind. And with that, and role related to the impact of trachoma, I'd like to ask Ms. Kim Jensen to take over, and Kim's going to talk us through this in the next section, and then Angelia will present more on her own experiences being a woman in trachoma. Thanks so much, Kim. The floor is yours.
Thank you, Kelly. And welcome everybody. We're so glad you're all here today. Kelly gave a great overview of trachoma in general, how it impacts the globe, and what the Carter Center is doing to contribute to the fight against blinding trachoma. I want to talk a little bit more about how women are disproportionately impacted by trachoma, as well as highlight some of the women who are contributing to the fight against blinding trachoma. So we want to know, why are women more impacted by trachoma than their male counterpart? Well, Kelly touched on it a little bit. Children under the age of 9 harbor the most infection. And as the caretakers of those children, women are put at greater risk because of their increased exposure to the children and thus the infection. So for those of you who are mothers or caretakers or parents, or if you're just a goofy aunt like myself, if our little loved ones have a runny nose or a goopy eye, we may likely would clean it for them, but we would probably use a tissue. In some of these instances, women are using their hands, and as Kelly said, they're using the bottom of their skirt. They may use their scarf to wipe the face of their children. If they're unable to clean their hands or their clothes, then they could take that infection from the children and give it to themselves, continuing that trachoma cycle. And as Kelly mentioned, with repeated infection, we can develop what's called trachomatous trichiasis. So that's when the scarring of the inner eyelid starts to make the eyelashes turn inward and make the eyelashes scratch the eye. You can imagine that is quite a painful experience. Women suffer at a rate of 2 times that of men because of their increased exposure to the infection as caretakers. But there is a solution, as Kelly mentioned, that 20-minute surgery by TT surgeons can turn those eyelashes back outward, so women aren't suffering with every blink of the eye. But surgery is not the only option. As you can see, there are some alternatives here. The woman in purple has something around her neck. Those are the local tweezers. That's just about a bent piece of metal that forms tweezers, and she will take that and pull out the lashes that are scratching the eye. So you can imagine that is also a painful procedure, but she will find some relief after that. Kelly also mentioned that children don't tend to develop TT, which is true because it requires a repeated infection of trachoma to develop that scarring over time. But in some of these very trachoma endemic areas, the frequent infections can take place very close together, and thus children, like this young girl in the green and yellow, can develop TT at a young age. And again, I believe Kelly said this as well, bilateral or unilateral TT is possible. So people, if they have TT in both eyes, can get surgery in both eyes in one day, because it's only about 20 minutes. Some people choose only to do one eye, and those tend to be women because they might choose to do one and hope to come back to do the other when they are able to still care for their children. The idea of having both eyes bandaged, even just for 24 hours, is something that they can't necessarily do. So in addition to treating the TT, we are doing things to prevent the TT. As Kelly mentioned, antibiotics is one of the big components of the SAFE strategy, and we distribute that through mass drug administration, or what I'll call MDA. And MDA comprises a very large element of the fight against trachoma. In fact, to date, Pfizer has donated nearly 1 billion, that's billion with a B, doses of Zithromax to the global program. And as Kelly mentioned, over 213 million of those doses of antibiotic have been distributed in areas where the Carter Center is assisting the programs. Now, this is a tremendous feat and requires a lot of support from the community drug distributors, the community health workers, and volunteers, many of whom are women. And this is very true in Ethiopia, where the Carter Center is assisting the Amhara region in the trachoma control program. So in Ethiopia, they use women health extension workers, who are their community health workers, as well as the health development army members, and those are community volunteers. And these women contribute greatly to the MDA activities. To put it in context, on average in a year, there may be about 14 million doses of antibiotic distributed in Amhara, in just the Amhara region alone. So that's 14 million people who are treated in about a 2-week period with the help of about 43,000 health extension workers and health development army members. And that constitutes about 88% of the local workforce that is involved in that distribution over that period. It's a little bit different in South Sudan, however. So in South Sudan, most of the community drug distributors are males. And that is because due to the recording requirements, there is a minimal requirement for ability to read and write. So due to the increased illiteracy rate of women as compared to men, it is more likely that the community drug distributors in South Sudan would be males. Thank you.
Kim, before you move on, we actually have a question about
Absolutely.
the TT surgery.
Mhm.
Is there anesthetic available
Yes.
to the people? Okay.
Yes, they do use local anesthetic. And the beauty of it is and you'll see a photo that Angelia will show at the very end, that these procedures are not being done in sterile hospital rooms. They're being done sometimes in clinics, sometimes in schools, sometimes in churches. They just have the sterile field, but they do have anesthetic to make sure that the individuals are not experiencing pain. And then they are given acetaminophen as well as tetracycline eye ointment and azithromycin or Zithromax to prevent postoperative infection.
And how involved is the aftercare?
It's pretty minimal. They actually come back the next day, so 24 hours later, to remove the bandage, to assess that the surgery was done properly. Sometimes it's possible that the eyes are overcorrected, which means that then the eyelids might have difficulty closing. And if they come back at that 1-day period, then it can be corrected so that it can heal properly. They also might make sure that it has been corrected enough so that the eyelashes are not touching. So it's keeping it clean, and the eyelid actually heals pretty quickly, which is why after 1 day, the bandages can be removed, and it's just about keeping it clean and putting that tetracycline eye ointment on it to prevent infection.
Got
And
it.
to
Thank
add,
you.
Kim and Amanda, the sutures are absorbable. So once the eyelid is numbed and the incision is made to rotate the eyelid, sutures are then put in place to hold that, and they are absorbable into the body. So that reduces any risk of infection. Thanks, Kim.
And thanks for the question, Amanda.
Yep.
So in addition to the MDA, we have a lot of community health workers, community drug distributors contributing to health education, as well as the TT case finding, which is when they go house to house looking for people who may be suffering from TT. And this in Ethiopia is still done with the female health extension workers and health development army. In Sudan, however, it's a bit different, where they usually have a man and a woman going together. And this is to address any of those instances when a mother may be home alone with her children, and it would not be appropriate for a man to go into the household, but it would be okay for the woman to go into the household. And similarly in Niger, if they're doing case finding, looking for those TT cases, they also would tend to like to go with a man and a woman, so that if a woman needs to be examined to see if she has TT, it may be more appropriate for another woman to examine her rather than a man, and vice versa. So we've already talked about the women who receive the TT surgery. Now we need to talk about the women who are doing the surgery. In some areas, you're definitely going to see that there are fewer women doing the surgeries than you would see participating in more of the community level activities like the health extension workers. As Kelly mentioned, in Ethiopia, in Amhara specifically, of the 264 TT surgeons, only 30 of them, or 11%, are women. And in Niger, you'll only see about 20 to 25% of the surgeons that are women as well. In Sudan, however, it's a bit different. Most of the ophthalmologists are in fact women. The difference is the women have a more difficult time participating in the surgical camps. So the surgical camps, during the surgical camps, you may be away for 2 to 3 weeks, depending on how far it is from where you live. And so some of these young professional women may have young children, may have families at home, and they cannot spend long periods of time away from their home. So this prevents them from participating in those camps and preventing them from participating and getting more practice in TT surgery. On the other hand, if we think about the programming, it's also more difficult to plan those activities because the majority of your ophthalmologists or the people who are eligible to do the TT surgery are women, but then again, they are unable to participate in all the surgical camps because they are the ones they need to be at home and cannot be away for so long. So before I hand it off to Angelia, we're going to show you a quick video here showing the TT in action in South Sudan. So in general, as Kelly mentioned, there are very few TT surgeons in general in South Sudan, and even fewer women. There was, in fact, a woman that was participating in this surgical camp, but unfortunately, we don't get to have an interview with her because she did not want to give an interview. But hopefully, you'll see a glimpse of her, and you'll see all of the women who are receiving TT surgery and all of the great work that's being done in South Sudan.
Trachoma is an infectious eye disease.
That person is in agony all the time until you are relieved by surgery.
This center at the moment is doing trachomatous tracheasis surgery camp that we started 3 days ago.
In a health facility, you may not get enough rooms and enough space. We resort to using any building that is around, and then we can clean it and start to make our own theater.
And then we were availed with this one here. We came, the whole thing was a mess. We had to do 2 days cleaning, disinfecting for 2 days before it started. So it's really a challenge to us.
We have electric autoclave, but it cannot work here because there is no electricity. So as now we are using the one that uses charcoal. We have to improvise a number of things to make the work go on. We have a lot of challenges in terms of mobility. Some areas are hard to reach. The war between the rivaling groups, it makes our movement so difficult and we cannot cross from one area to another. We find it actually very difficult, but we have to do it because the service there needs us. In the community there, we also have challenges. Some communities do not understand the importance of the surgery.
We have those rumors in the communities that these people are coming to remove people's eyes and so on.
For them, they may believe it was by God that they go blind. They don't know that some people can help them somewhere.
But when they come, they see the first people who will be discharged, they will not really disturb.
We have assistants in the field, and even in the theater, you will find some people assisting us. And these are not people who are trained somewhere, but we are not training them here locally to help us. So we are very few in the country.
It leads to irreversible blindness. Since we are few, I have to do what I can do to help my people.
It worries me because even the workload alone is overwhelming me. We are going to operate you and you are going to be okay.
Though there are some mild pain, but with time, they will be fine. And they will really feel the difference.
We have a lot of patients that we operated, and most of our patients are doing well. And later when you visit them in their places when we are doing follow-up, they will be very happy, greeting us. They are very cheerful.
Whenever the community appreciates our program, we feel happy.
We don't do it actually because we are gaining out of it, but we feel it is our role. It was my call to do so.
Together with the team, we were able to make the place a better place for helping the needy. It makes me happy and very proud because these are the very people I'm supposed to help.
Right. That's by far one of my favorite videos. I don't know how many times I've seen it, and I feel like those videos, whenever you get frustrated by your work or different things, it's always nice to watch something like that and just get things back into perspective. Perspective
Yes.
is always very useful.
Quite powerful.
Yeah. So with, in addition to what Kim was talking about in regards to how women both support implementation of the SAFE program and are also recipients of it, I wanted to highlight just women's impact on trachoma through research. So women have been involved and are currently involved in research through either being one of our epidemiologists at the country level. So epidemiologists are the ones that help design studies, data collection, analysis, things such as that. Also clinical graders, and graders are those that go into villages and they flip eyelids of children in order to see how bad trachoma is, and we use that information in order to really manage our programs, to give us a sense, is this a problem that we're going to be needed in the communities for years to come, 10 years to come, 1 year. And so that contribution is just very important. We also have the data collectors, so those who are there with their phones and tablets, documenting the information that they're collecting as part of studies or just routine monitoring and evaluation. We have nurses, such as the picture here, you see a nurse in Darfur, Sudan, collecting blood samples as part of research that is currently being conducted with the US Center for Disease Control. And then also having women involved in study design, coming up with ideas of how best can we get the information that we need. So both women involved in conducting studies, but also it's important that we develop studies that look at women as recipients and members of their communities, because we are all different from each other and we have different needs. And so how can we tailor messaging or the services we provide based off the needs of different members within the communities? So for example, as part of my doctorate research, I have started laying the groundwork that unfortunately, I saw one of the questions about how COVID is impacting things. Some of our research has been impacted by COVID. So I plan to go back to the community that I lived with in South Sudan and work with mothers of young children to really understand who they are and what their needs are and what we can do as a program to support them to keep their children's faces clean and just to support them within their communities and as part of this program. So looking at women as both data researchers and also as recipients of research. And then lastly, it's just very encouraging when we have women that take the research that's been done and they write articles for peer review publication and become published about the work that they've been doing. And I've taken some screenshots and put here about different topics that women within the Carter Center have published on.
Angelia, another question for you. So in the video, they were talking about the general hesitancy of people in the communities to receive the treatments that they need. Have you seen that women are more hesitant than maybe the male members of the community to receive the services? And is that why there's more of an emphasis on engaging more female ophthalmologists and service providers?
Yeah, that's a really good question. I see hesitancy among everyone because there's something about having, we're all quite protective with our eyes. And I tell people, like, I understand that when you start talking about eyes and getting sharp things next to your eyes, you just get a little uncomfortable. I wear glasses because I can't bring myself to put a contact in. And so I get it. And with women, one of the challenges that we have frequently seen and that Kim alluded to is connected to their childcare responsibilities. And so you do have a recovery period when their eye is bandaged for the first 24 hours where they are not able to see out of it. And at the end of the day, if you're getting a surgery in the morning, you're still expected to provide the meal and care for the children in the evening. And what we did in South Sudan that I'm really proud of is we identified this was the biggest barrier. And what we ended up doing is we would get really big hospital tents and we would set it up next to the clinic, and we would keep the women overnight. We would provide them with a sleeping mat and a bed sheet, and we would say, bring your children that you're responsible for. We are going to cook for you, we'll have water for you, and we're going to take care of your needs and your children's needs during that initial 24-hour period. And when we started doing that, just the receptiveness to surgery immediately went up. And you really saw that it wasn't their unwillingness to get surgery, they just couldn't step away from their responsibilities in order to get it, even though they knew how important it was. And so that was something that's just very directly connected to meeting that need. And then it's also recognizing their responsibilities seasonally as well. So there are, I think everywhere where we work, most women either have a garden that's attached, sort of their farm. I mean, these are communities that are subsistence farming, and what you eat is what you grow. And so the last thing that you can do is not work in the fields because you need to get a surgery. And so you then need to organize your surgery camps so that you're not asking women to make a choice between growing maize or getting the surgery. And so really kind of being very strategic in when you organize your activities and how you organize it. And that being strategic is about knowing the communities you work with. If you come in without knowing your communities, then you're going to be sitting there wondering, why aren't people coming for this free service? Well, it's because you're not tailoring it to their needs.
Right. No, what an incredible example of meeting people where they are. Thank you.
Yep. So with this picture, just kind of briefly, I think it just highlights, again, that working together and the importance of coming together for communities, and just really the achievements that have been done are because of this just very collaborative spirit. All right, so this slide will have a few different pictures, and I just wanted to kind of highlight, to give you a day in the life of, if you will, working in with the Trachoma program. So I lived in South Sudan for 4 years, 3 years with the guinea worm eradication program, and then 1 year with Trachoma. Before I took on this current role as associate director. So these pictures are taken from my time living in South Sudan. So the first picture is sort of just an aerial view of one of the communities that we work with. And so all the different circles are the different villages where people would live. And so it gives you a sense of just kind of how spread out. This isn't like you're going to an apartment building in downtown Atlanta or whichever city that you're in, and you can just take the elevator up and down between people's apartments. So it's very spread out. It's time consuming to move through different communities in order to implement activities. Next. Some of the geography is very difficult to work with, and so you kind of have to have the different tools in order to reach the different communities. This picture, when I first arrived in South Sudan, I noticed that all the other technical advisors and program officers had these Land Cruisers. And those are, I don't know what, like a truck, just kind of your average truck, if you will. And then they pointed to this one, and so the day that I was supposed to depart for my compound, the sort of the sub office, I went and stood by the Land Cruisers, because there were like 10 Land Cruisers. And then they pointed to this red vehicle and they're like, no, this is yours. And I'm like, wait, why does everyone have this car and I have this monster truck? And they're like, oh, that's because you're up on a mountain. And the only way that you can get to the top is by this heavy duty German monster truck. And I mean, it was quite fun to ride in, but it just kind of gives you a sense of the terrain is just very different, even within a country. But I would say that most people's commute does not involve a monster truck. Next. Also, the house that you live in, a lot of time is spent in the villages, just because, again, when you talk about meeting the needs of the communities that you're serving, if we are there during sort of that planting season or harvesting season, most people would leave very early in the morning. And so in order to reach people before they start, if you will, their day job, you need to be sleeping in the village. So this is a tent from REI that I still have and I still use. I'll be going back to South Sudan this summer, so I will be sleeping in this tent. And there would be times that sleeping in this tent for 2 to 3 weeks at a time, just moving between villages and being there and working with the teams in the villages and also working with the communities. I will say, for whatever reason, goats really like sleeping against the tent. So you would wake up with this like indent of a goat like nestled on the outside of the tent, and they're also very loud. So that it provided an interesting wake-up call in the mornings. Next slide. This shows some of the water that's commonly found in communities. And this is why there is a very big push to provide safe, clean water to communities. And this water here, you can see it almost looks, I mean, it basically looks like chocolate milk. And this is water that people bathe in, that the cows and animals drink in, and that also people collect water, and this is what they cook with, and also what they drink with. And this particular picture was taken while I was working with guinea worm, and we were treating the water to prevent guinea worm. But it gives you a sense, and this particular water source was their main source of water within, I think the next closest, like a borehole or a deep well where you would have clean water was about 3 miles away. So this really was the only source. Next picture. So this is the showering facility on a good day. So this one, you actually have sort of walls, and you would have your bucket bath, which it's a fine skill, learning how to get water cupped in your hands and not like thrown over your shoulder. And this was, again, like this is when you're lucky. A lot of times you would be bathing sort of out behind bushes. So I would say that as a worker, especially you're a novelty because you're not from that community. So you do have children that tend to follow you when you're trying to find a place to shower. You definitely get over your modesty really quickly. So kind of overcoming sort of your cultural modesties is probably step one when you're just working in different countries. Next picture. When you're ideally, you want to have access to a pit latrine. Very rarely was that the case. And this is a picture of a pit latrine that I was very, it was really great because we actually had a pit latrine. However, this particular few days, next, the circle will show up. This was a lizard, a ginormous lizard that was in the pit latrine. So we definitely were trying to like put chicken, we like buy a chicken, slaughter it, get chicken pieces, and trying to woo the lizard out of our pit latrine so that we could use it. So this just kind of gives you a sense of the dynamics working in some of the countries, especially, this is connected to South Sudan. Next
I bet that was not in your job description.
Yeah, it wasn't. Like, is it an alligator or is it a lizard? This is definitely, it makes me think that like ginormous lizards in New York, it's must be real because yeah. But I would say that through it all, it's always worth it. This is a picture that I took in South Sudan when I lived there, and I think it just really captures a lot of what Kelly, Kim, and I have talked about. This is a pregnant mother, a pregnant woman who traveled with her husband, and you can see her husband sitting at her feet. And they had traveled for a day because they heard that trachoma surgeries, in order to correct the eyelids, were being offered. And there was no clinic in this area at all. And so this surgery is actually being done in a church which has mud floors, mud walls, and we were able to negotiate with the church to allow us to conduct surgery during the week when church was not in service. And you can just see that from the floor, this is not your typical surgery theater. And the bed is actually a camping bed that we purchased from REI here in Atlanta. And we use this type of bed because it's something that we can pack up and carry on our backs in order to walk to communities that cannot be reached by our vehicles, because we know that they're not able to come to us. And the only way that they will get the services is if we walk the supplies out to them. And really, what this shows is that this soon-to-be mother traveled a day to get surgery because inside of a church on a camping bed, because she didn't want to be blind when her newborn was born. She wanted to be able to see her newborn, and she wanted to be able to care for her child. And we were able to provide that to her. And I think just through this work, by helping her, but not stopping with her, but continuing the work, is to ensure that her child does not have to be at risk. And that I don't want to see this woman's child in 10 years, because that's how bad TT is in these communities, to be also at risk of going blind. And so it's for that reason and that motivation, and really through the dedication of everyone at multiple levels, that we're able to move forward and do this work. So lastly, just to conclude with looking forward, Kelly discussed earlier about some of the challenges within the countries and also what still needs to be done. And I just kind of really want to re-highlight the big themes and really where our gaps are and what we're looking to do moving forward. The big thing is really having more women TT surgeons at the local level. So having that capacity in local levels means that you're not asking someone in Sudan, in the capital, to be away from their families for a few weeks, because it then changes from being this long program far away to being something local, like eye care services are provided at a local level. We also want women-centered research conducted by women who have been trained to conduct this type of research, and then also focusing on the needs of women within communities so that they can continue to be engaged and really take ownership in preventing trachoma within their communities. And then lastly, provision of water and sanitation. We do know that women spend a lot of time during the day collecting water for their families. So if we can bring that water closer, that helps them do more, both because they have more quantities of water and then also more time. But in order to make this happen, one of our biggest needs continues to be funding, because the commitment is there. It's just the means to do it. And with that, we will turn over for questions.
Thanks,
Yes,
Angelia.
so we invite everyone in the audience, if you do have more questions for Kelly, Kim, and or Angelia, please put them in the Q&A and we will make sure that we get to them before we close out for the day.
Amanda, I'm going to
So,
jump right
yes.
in with,
Sure.
let's talk about COVID, and let's talk about what that's done.
That's everybody's number one question.
Well, last year on April 1st, we received a message from the World Health Organization, which I did think was an April Fool's joke, that we were to shut down everything immediately, anywhere that we could possibly introduce community transmission. We knew COVID was going to have an impact, but shutting ourselves down in such a quick fashion was disconcerting. We were in the middle of MDA campaigns. We were in the middle of TT surgical services campaigns. So Kim and Angelia had to work quickly with our partners, with our countries, to finish what we were doing and to then put a stop to any of our community work and to begin looking at risk assessments and mitigation actions. How could we assess risk for COVID transmission, and what could we do to mitigate our work once we were able to resume? On July 27th, the World Health Organization lifted that stop work request. And so we were able to begin working again, but we had 4 months where we were not able to do any work within the communities. We were able to do some work in the background, again, developing a risk assessment mitigation action tool and revising all standard operating procedures. Kim has worked really hard with our Ethiopia program to make the switch from mass drug administration campaign style to around 16 to 17 million people, to move that and transition that to a house-to-house campaign with all new standard operating procedures. We had to quickly figure out how to supply personal protective equipment to our frontline care workers, and to how to train them on physically distancing, how to use thermometers, how to physically distance in cars. So our logistics increased in a moment. We went from using 10 vehicles for a survey to having to use 20 vehicles per survey. So COVID impacted us by shutting us down for 4 months, gave us an opportunity to revise our standard operating procedures so that when we were ready to resume activities, we resumed them with all new operating procedures. We started resuming activities around October and November in earnest, and have been conducting surveys, mass drug administration, and TT. Unfortunately, because of the requirements of personal protective equipment, masks, hand sanitizer, and thermometers, and physically distancing, that's causing us to have some increased costs, increased effort, and increased time. But we are looking at catching up, if you will. Kim and Angelia have both been working very hard with their respective countries to assist them in how we can quickly in 2021 and in 2022 catch up with the losses so that we can be back on track to where we thought we were. So COVID has had a great impact. Also, I should say that Kim and Angelia and myself and the rest of the team have not been able to travel. At the same time, we had to get really creative in our supervision and monitoring and evaluation using the virtual world. So we've had increased team meetings, increased Zoom webinars, and things of that nature. But we were able to hold a program review. The Trachoma program reviewed all the countries, and we had, I believe, 170 participants from all of our countries, the World Health Organization and our implementing partners, and many donors. And we were able to review the progress last year and make plans so that we can catch up in what we missed during the COVID stop work orders.
Oh, well, that's wonderful. A couple more questions from the audience. Maria Ward has a question about the post-op picture of the pregnant mother. So there are no windows or doors in the structure in which the mother is receiving the procedure. What's the benefit of bringing the patient inside of the building? Is it just for privacy? And what do the surgeons and service providers use for light?
That's a really good question. And it's actually because of during the day, it's so bright that it's difficult to do the surgery just because of the glare. And also in South Sudan, it's very hot. And so at least inside, it's a little bit cooler. Yeah, so, and that's constantly a challenge, is how do you weigh finding a place that's suitable to conduct a surgery, also looking at challenges. I mean, at one point we were looking at how to sort of create a really big mosquito net that could surround people, because you would have this sort of open air surgery and you would have flies that are attracted to, you know, the different fluids in the blood. And so we went and we would when there was a lot of flies, we would put up sort of this big mosquito net around us. And so it's working with what you have as much as possible. And then in this case, we had enough light that we were able to do the surgery, but the number of hours during the day that we could do the surgery was based off those things. And then also, I mean, REI, we're a huge fan. This isn't a plug for them. We just get a lot from them. But even just the headlights that that you get for camping, that would be something that the surgeon would wear the headlights, and then they would have their surgery glasses, magnifying glasses for when they would do the surgery.
Awesome. Thank you for
President
that question,
Carter
Maria.
Amanda, President Carter once said that he'd do whatever he can with whatever he has, wherever he is, to improve people's lives. And Angelia has worked really hard at bringing that quote into all of her work into South Sudan, because you have to get very creative. And I would also say that's in the midst of insecurity. All the countries in which we work, all 5 countries suffer from insecurity. So not only are Kim and Angelia women in Trachoma that put themselves in really difficult situations, but they're insecure situations where they have to come up with creative solutions to make sure that we are working to fight disease and improve people's lives. So that insecurity element is another one we didn't talk about as much, but it is definitely challenging being women in Trachoma and working in insecure areas and being creative at the same time.
Yes, indeed. So we have time for one last question, and this is coming from Robert Sink. Is trachoma only in Africa?
It's a good question, Robert. We used to have it in the United States of America, actually, at Ellis Island, when people were leaving Europe in the 1940s. We actually flipped eyelids at that point in time to check for trachoma. President Carter remembers it in Plains, where he grew up. And he remembers Miss Lillian trying to treat people that had trachoma. So it was in America. The age of sanitation and moving sanitation indoors stopped the fly population and eventually caused trachoma to not be a problem here. Also, the use of antibiotics increasing. So it was all over the United States. It was in Europe as well. And currently, there are some areas in Asia that still suffer from trachoma. And there are some outlying areas like in Australia and the Pacific Islands. But the bulk of trachoma is in Africa, and 51% of all the trachoma in the world is in Ethiopia. Ethiopia harbors the worst known trachoma. Although I will say again, we don't know what that looks like in South Sudan. Once we do the baseline mapping, hopefully that will cut Ethiopia's portion of the trachoma problem down by a bit.
All right. Thank you, Kelly. Thank you, Kelly, Kim, Angelia. I think I can speak for everyone when we say that we've learned a lot today, and we deeply appreciate the work that you do here and across the world, treating women with trachoma and helping to empower women within their communities. Thank you very much.
Thanks, Amanda. We could not do this without the support of all of you, and we greatly appreciate everything you do with and for us, so that we can stop people from going blind from trachoma. And REI is not a donor. Unfortunately, we buy from REI. Angelia made several REI plugs. We appreciate REI, but they're not a donor. And again, we greatly appreciate all of you. Thank you for your support.
Yes, and to echo that, every single one of you who joined us in the audience for this video, thank you for your time. Thank you for supporting the Ambassador Circle. We quite literally couldn't do the work that we do without your support and your partnership, so thank you. I also want to remind everyone that you will receive an invitation soon for an invitation to the Carter Center weekend, which will be virtually on Saturday, June 26th. I also want to plug our last month's Ambassador Circle webinar is now available on our website, where we did a panel interview with our new Carter Center leadership. And if you have any additional questions about the Trachoma program, Ambassador Circle, or any Carter Center related questions, please feel free to reach out to us. You can reach the Ambassador Circle at ambassadorcircle@cartercenter.org, or you can give us a call at 404-420-3814. Again, thank you so much to everyone for joining us this afternoon, and we hope you have a wonderful rest of your day.
Thanks, everyone.
Thank you.
Bye.